everyone, this is your little snippet of a quick PowerPoint voiceover on gallbladder or cholelithiasis. It's an inflammation of the bladder, and this could be really for anything, whether it's infection, gallstones, I wouldn't say there's a million different reasons why, but it's really just the inflammation of that gallbladder itself. And this actually could really be removed. I throw this out there because gallbladder surgery or gallbladder removal is actually a very common procedure that's done all the time. And it's probably mostly due to our culture on a whole and the diet and just the crap. I didn't say the crap that we eat, but I'm pretty much the first person to, throw stones. So anyways, but the way I actually remember gallbladder problems is for patients that are typically 40, fat, and fertile. It's the 3 Fs. That's how I was taught in nursing school. I'm teaching you that this time because it tends to be that population that tends to have the gallbladder problems. This could either be acute or it could be chronic. The acute is usually caused by stones, and again, I've seen gallbladders that are completely full of stones, and I've seen some gallbladders that have 1 or 2, and it's just a matter of them passing it and where did it get stuck. It's just like a kidney stone. It's just a matter of where did it go, where did it stop, and is there actually any problems from it. With cholelithiasis, gallstones are hardened deposits of digestive fluid. Gallstones can vary in size and number and may or may not cause any symptoms. I've had patients that have lived for years with 1 stone and it didn't do any problems, and all of a sudden it just comes out, and next you know they're in a lot of pain and they have to have it removed. People who experience symptoms usually require gallbladder removal surgery. Gallstones that don't cause symptoms usually don't need any treatment. So again, you either know you have a bad gallbladder or you don't, or you know you have stones and you pass them or you don't. So again, I think it's just really a matter of diet and the way you eat, whether or not you're predisposed to them, maybe even family history. But for the most part, if you don't have any problems, you probably won't ever have any problems. And let's see here. For assessment, you're going to have nausea and vomiting, you're going to have indigestion, belching, and flatulence. There is going to be epigastric pain that radiates to the scapula 2 to 4 hours after eating fatty foods and may persist for 4 to 6 hours. This actually makes sense. If your gallbladder is designed to push bile based on breaking down fat, if you eat a big meal or any meal and there is fat in it, the gallbladder will push that fluid out to actually break that up in the digestive tract. So by the time it actually hits the tract and it's actually being done, it's going to be 2 to 4 hours after eating those fatty foods. And now, as far as lasting 4 to 6 hours, your food, as much as you eat or as little as you eat, it's really slowly processing through your intestines. So 4 to 6 hours sounds like a pretty good time frame for it to go from one place to another. Pain is localized in the upper right quadrant. You do actually have guarding. You have a mass palpated in the right upper quadrant, which is really just the inflammation of that gallbladder itself. I put in the YouTube video for the Murphy sign. It's actually very quick and it's pretty easy, but I thought it was very interesting to be able to see that Murphy sign. Temperature could go up. That's really either an indication that there is some sort of infection, or because of the fact that they're dehydrated, that could also be elevated as well. For labs, you're looking at amylase and lipase, and the reason why is because of the common bile duct. I mentioned that in lab today. So between the liver and the pancreas and the gallbladder, they all share a common bile duct. So if there is a stone that actually has occluded that duct anywhere from where the liver meets it and the pancreas meets it, then you're going to have a backup of enzymes. So again, you're going to look at amylase, lipase, all the liver enzymes, whether it's the AST, ALT, ALP, all those things, because like I said, you're really going down the road. It's really just trying to figure out which path you really need to take. For interventions, obviously your patient is going to be NPO, whether it's NPO because they're nauseous and vomiting, NPO because of the pain. They're NPO because whatever you feed them, the gallbladder is going to have to work in order to push that bile out in order for it to break down the fatty food. So NPO for that sake, nausea, vomiting, and pain. Or they actually may come in the middle of the night, find out that they have a gallbladder full of gallstones, and then the surgeon who's actually on call might just say, you know what, let's just take it out. So NPO just allows your patient to go to surgery without to worry about it. Nausea medications, We have phenergan, Zofran, and Compazine. I know you've heard about these before. I don't think phenergan is necessarily needed in this disease process. I think Zofran probably work just as well. For pain meds, I think morphine will do well. I would not necessarily do Dilaudid. I threw that in there just based on pain management. But usually once people get their gallbladder removed, they actually feel so much better than they did before. I did throw in here anticholinergics because you have learned them for neuro, and there is oxybutynin in the Detrol. I threw this in there because of the fact that the gallbladder itself is constantly squeezing in order to actually push out the bile. If the stone is present and it's constantly squeezing and it's not able to do anything that's causing pain or problems, an anticholinergic which slows things down and actually relaxes smooth muscle, this actually may help. I also think that if you actually have that much of a problem with your gallbladder, they would probably really just remove it than start you on some sort of Ditrol or Ditropan. One thing I also want to mention too, a couple semesters ago in your book, I had a student point out that for pain management for a gallbladder, that you should not use morphine because morphine could cause more of a spasm or a problem with the gallbladder itself. That is actually true. The problem we run into is the book also tells you that Demerol is probably a better choice, but in the real world of nursing, and I'm sure NCLEX would not ask you this question, but in the real world, we do not use Demerol on a med-surg floor. There's too many side effects and too many problems. They can do it for surgical areas because there's a lot more nurses and a lot more things available to them. When you're on the floor, you've got 4 patients or 5 patients you're taking care of. You don't need the ones that are like, okay, let me push the Demerol and then have to sit there and stare at them the entire time while you're getting it. And make sure that you're monitoring them much, much closer. So they really just decided that med-surg was not the place for Demerol. Diagnostics and surgery. So what labs would you look at? We did talk about the liver enzymes, the pancreatic enzymes, and the gallbladder. So like I said, if there's something stuck in that common bile duct, it's really going to affect all 3. If it's far enough down on the duct, or if it's high enough on the duct, then it may not affect all 3. So like I said, you drew all the labs just to make sure that you're going down the right path. As far as diagnostics, they will do an ERCP, which is an endoscopic retrograde cholangiopancreatography. Again, they're really just going in and going all the way through your orally, all the way down to the actual stomach, and then going into the intestine to be able to go the common bile. They could do surgical removal, which is laparoscopic. I described it as being 3 probes that look kind of like the size of number 2 pencils. Basically, it's 3 puncture sites. They go in, they chop it up into little pieces, and they just pretty much suck it all out, and then you're done. It's easier to heal that way. It's easier to recover. It actually isn't too bad. And probably within about maybe less than 24 hours, the patient will probably go home. If the surgery was done early in the morning, they probably could go home that evening. Things to remember postoperatively, as far as make sure that you do your vitals every 15 minutes, every 30 minutes, every 45 minutes. You're doing it as to make sure that there's nothing going wrong. You also are going to instruct your patient on education of the puncture site itself. No baths, no jacuzzis. Don't submerge yourself in water because those 3 puncture sites will fill up. Now you've got, my thought process on jacuzzis and baths. You're swimming in your own filth. So you don't need those holes to fill up and to actually, those are holes into your belly. So you don't need that filth going in. Making sure that they're, doing your clear liquid diets, advanced diet is tolerated, making sure that you don't get sick. If they do go home within that 12 or 24 hours, have them go home and do clears and just take it easy. Don't go home and eat a steak. You do not have the ability to break down fat anymore. So it's really just a matter of the body actually getting used to it and adjusting to it. So it's just a matter of, like I said, to go slow and just take it easy. Don't lift anything higher, heavier than a gallon of milk, and then, upgrade to a basket full of clothes, and then you can kind of do it. But within a couple of days, they should start feeling better. Definitely teach them about pain management. They'll probably send them home on Percocet or Vicodin, but not very much. It's really much just a couple days worth and stuff. And like I said, just go home, lay on the couch, watch TV for a couple days. Get up and move as you need to prevent, you wouldn't get bed sores, but just making sure that you get up and move, make sure that you're drinking enough fluids, making sure that the bowels are moving, the lungs are moving, and everything seems to be pretty good. So, but yeah, this is a very easy disease process. Like I said, if it bothers you, just remove it. So, all right, let me know if you guys have any questions.